And joining us now on the debate, Udo Schuklenk. He is philosophy professor at Queen's University and chair of the Royal Society of Canada report, End of Life Care. And beside him, Joan Gilmore, professor at Osgoode Hall Law School. Larry Reynolds, professor in the Department of Family Medicine at the University of Manitoba. Ian Benson, senior associate counsel at Miller Thompson LLP. And Alex Schadenberg, executive director of the Euthanasia Prevention Coalition. Want to remind you, our online editor, Mike Miner, is hosting a live chat on our homepage. That's tvo.org/theagenda. So you can also send us a tweet at twitter.com/youragenda. We'll put your comments up on the screen throughout the course of the program. And it's good to have you all around the table today for what is a very timely debate. But let's all make sure, for starters, Udo, that we're speaking the same language. So when we talk about assisted suicide, what do you mean?
When we talk about assisted suicide, what it really means is that a physician, for instance, could prescribe medication to a patient on a competent patient's request, and the patient then takes the medication him or herself in order to end his or her life. So this is why the suicide component is in there. Voluntary euthanasia means the patient, for some reasons, might be unable to do it him or herself.
Perhaps they've got Lou Gehrig's disease or something,
for instance, but they are still competent, so they're requesting it, they're informed about what's going to happen, and a doctor actually, or a healthcare professional, would assist them in doing that.
Okay, Alex, why is this topic back with such a vengeance, so to speak? It seems to come in peaks and valleys, and we're at a peak right now.
Yeah, because last year it was in Parliament, and there was a bill in Parliament to legalize euthanasia and assisted suicide, and it was defeated 228 to 59. And now there's a case in the British Columbia courts, as you know, and as well as there's this report. It's been something that's been debated now for quite a few years in Canada, and I think the debate will continue. The important point here is that euthanasia and assisted suicide, what makes it important is it's about one person being involved with the death or causing the death of another person. So that's a very serious public policy question.
And that's why we're going to talk about it tonight. Ian, I think my first recollection of this becoming a huge issue was almost 20 years ago. There was a woman named Sue Rodriguez who had ALS and wanted to take her own life from British Columbia. Can you refresh our memory on the details of that case?
Yeah, Sue Rodriguez applied to strike down a portion of the criminal code that made physician-assisted suicide illegal. She failed to do so. The decision was a narrow one, 5 judges to 4, and the result is the criminal code provision was maintained, leading to a more widespread discussion culturally, and eventually a Senate committee. And that Canadian discussion was part of a long series of studies in different countries. England's been debating this question in the House of Lords since the 1930s. So it's a long, ongoing cultural debate in various countries.
And Joan, as Alex just said, it's back again because there's a woman named Gloria Taylor who is from British Columbia, has ALS, Lou Gehrig's disease, wants the right to end her life. She's going through this right now. Is there anything, to your knowledge, that's fundamentally different about her case from that of Sue Rodriguez?
In terms of the illness that she has, I don't think so, but there certainly are arguments to be made that the law should change, that may be somewhat different than were the case with Sue Rodriguez.
Go ahead, make the case.
Well, Charter of Rights, Section 7 of our Charter of Rights protects the right to life, liberty, and security of the person, and it's the particular focus on liberty then that would be, it would be argued, would be interpreted to support that right. This is different than what the Royal Society report was arguing, because they're talking about changing the actual criminal law. And so you have both the court case going forward and the Royal Society's report that urges a change in the law.
And where are you personally on this issue?
I would support a right to assisted suicide by a competent patient.
Okay, let's just actually go around the table here. You're obviously in favor, you are against. You haven't really said, where are you on this?
Well, as always, nuanced.
Okay, Ian, dazzle us with your nuance. Do you come down on one side or another clearly?
Yeah, well, I'm with the groups that have studied it the most broadly. The New York Task Force, I think, has the most powerful and persuasive set of arguments, much more than with respect to Udo, the Royal Society report that I've looked at. They had, for one thing, a very broad representation in their task force, and they came out very strongly and unanimously against changing the law in the United States. And there's nothing, given the nature of the objections they had, that would be particularly different in a Canadian context.
So we put you down as a nuanced against?
Yes.
Okay. Larry Reynolds, we still have to hear from you.
Yeah, I'm against it. I think as a family doctor caring for people in end-of-life care, I don't think it's the right answer to a lot of complex questions about end-of-life care, about depression, about the value that a human being has. It's one thing for someone to make a determination that their life isn't worth living, but for another person, like a physician, to agree, because if you're going to participate in physician-assisted suicide, you have to agree with the patient's assessment of their life. Your life is not worth living.
So if one of your patients who you knew to be competent came to you and said, I've got this horrible disease, I'm going to die of it anyway in 6 months, it's going to be a horrible death, I'd rather choose the timing of my own death right now, and I want you to prescribe me something to help me do that, what would you say to them?
I'd say, let's talk.
Okay, after talking, then what would you say?
I'd want to know what was the question behind the question. Like, what do they see in their life? What meaning can they find in that? What impact would that kind of death have on those left behind? What are they asking me to do? Because I have a relationship with this patient, maybe a 20-year relationship. You know, if I'm going to outlive the patient, I have to remember, did I do the best I could for this patient? Did I agree with this patient? You know, what are the issues of depression? What are the issues about how the patient understands the kind of care that's available to the patient?
It sounds like what you're saying, though, is that how you perceive your professional responsibilities and reputation are more important than what might be what the patient wants.
I don't see it in my mandate, Steve, as something in helping a patient. I don't see killing the patient as part of my mandate.
Udo, how would you respond?
Well, I think it's just worth pointing out that in other countries, like the Netherlands, for instance, an overwhelming majority of healthcare professionals, doctors, medical specialists, are in favor of the system that they have in place, so they do not believe there's a dramatic moral conflict to be had in the first place. And when you look at least some of the surveys that we have from Canada, in Quebec they queried medical specialists, and more than 2,000 in fact. And you had in excess of 70% of them being in favor of decriminalizing assisted dying.
But you know...
Well, I mean, no, sorry, the point I'm trying to make is, it is just not the case that across your profession there's a consensus on the question of whether or not individual doctors should participate in these sorts of things.
I don't think there's a consensus across any profession on anything.
That's what I'm
okay,
trying
so
to say.
I don't, but what I want to resist here is the M-deification. Physicians are not superior moral agents, despite all sorts of pressures to say that we are. We are not. We do not have superior moral training. We don't have a lot of ethical training. There's all sorts of policy decisions that are being pushed onto physicians. And of course, there are physicians who will respond in different ways. But
Joe, you wanted to say?
I did. I think it's also important to remember that under our current law, as it stands right now, patients can refuse treatment. And they can refuse treatment even when it is life-sustaining. So if, for instance, a patient is being maintained on a ventilator to support her breathing, she can refuse that treatment. And indeed, that issue has gone to court, and her right to refuse the treatment, and therefore her right to assistance in removing her from a ventilator by healthcare professionals, is confirmed in law.
So we presume she is competent to make that decision.
A competent patient, and I'm only speaking about patients who are competent.
There is a big difference between actually killing somebody or being involved in the suicide of somebody or letting them die. Because even in the ventilator case, you remove a ventilator, that person, if they die, and often they do, usually they would, what do they die of? They died of their medical condition. Nobody actually caused their death directly. They died a natural death.
That's a little bit of splitting hairs, I think,
It's not splitting hairs.
someone's life is maintained on a ventilator.
Stand by. We got to go one at a time here.
So the case that I was talking about, Nancy B., and it was a Quebec case, and it's older than the Sue Rodriguez case, but it's a case where she was maintained on a ventilator. She was suffering from Guillain-Barré syndrome, which had essentially paralyzed her, and she had decided that she wanted her life to end. And it went to court because the hospital and the healthcare providers were concerned about potential liability should they actually accede to her request. And the court confirmed that patients can refuse treatment, even when that treatment is life-sustaining. That's their right, and everybody in that room knew that the result of this was going to be that she would die, and that was what she wanted.
Yeah, let's get in then, Alex.
This is a common mistake, actually, and it's certainly present in the Royal Society's report. To fail to see a distinction between somebody who falls off a cliff and pushing someone off a cliff is a startling omission in ethics, and it seems to be a common mistake. To say that there's no difference in intent between intentionally causing the death of somebody and letting, in a sense, nature take its course in the course of an illness is an astonishing
Just hold that.
mistake, and
Udo,
it's very
would you-
common.
Okay, you would acknowledge there's a difference.
Well, in actual, it depends.
No.
I mean, if you, of course not. Of course not. And what you consider like clearly a mistake is very controversial in moral philosophy, as you know. So you're bluffing in a way. You through an argument here. For consequentialist philosopher, for instance, somebody who cares about outcomes would say, well, whether I omit to act, and I can foresee that a certain outcome is happening, or whether I act to achieve the same outcome is really, as you said, it's just splitting hair with it. It is in the end the same
term
thing.
splitting hairs is used by the in the Royal Society report, and with great respect to them, it's a very, very slippery sleight of hand.
Okay. Alex, you wanted to
That's
say?
been for centuries
I
the
don't
central
even know what-
distinction in medical
I
ethics.
don't even know what that means.
You see,
Okay, hang on, let's
when
go
we're
down
talking about euthanasia and
Mixed
assisted
metaphor.
suicide, we're actually talking about intentionally causing someone's death. And there's an important point to it, that there's an intention. Like you're involved in assisted suicide, you're intentionally involved in it.
And intentionally omitting to do something and creating the same outcome. I mean, you're splitting
It's
hair.
not the same outcome, and I could prove it very simply.
Yeah.
If you withdraw life-sustaining treatment, the question is, do we always die? But if you give me a lethal dose, I will die, and I will die of that lethal dose. But do I always die? And the answer is obvious, no, they don't always die, and they certainly don't die immediately if they do die. And when they die, what do they die of? Their medical condition.
Let me give
It's
you
a totally different comparison.
Let me do a for instance here from the report. This was something that the Royal Society of Canada report had in it as an example. Michael, if you would, bring this graphic up. A 44-year-old man has advanced multiple sclerosis. He is still living at home with supportive care. He is concerned his quality of life will decline to the point at which he will be entirely dependent on others to care for him, and he will no longer be able to do any of the things that bring him pleasure in life. He asks his physician to write him a prescription for a barbiturate and to give him instructions for how to use the drugs prescribed to kill himself at the time in the near future when he wants to die. Okay, Joan, is that legal for that doctor to prescribe those drugs?
No,
That would not be legal today in Canada. You would like to see that changed.
I would.
Because?
Because I think that a competent adult should be able to make that decision for themselves. I think that how we die is also a part of how we live. I think that we have very important autonomy interests and interests in our own bodily integrity that would be advanced by recognizing a legal right to assisted suicide and voluntary euthanasia for competent adults.
Larry, you want to come back at that?
Well, what about depression, though? Does depression make somebody incompetent, Joan? I mean, that's the nuance here.
There are legal tests for whether somebody is competent or decisionally capable, right? And it is not the case that everybody who's depressed is not decisionally capable.
No, exactly.
We all know too
So-
many people who are
so-
depressed that we don't think they're decisionally
So we
incapable.
don't treat depression by killing the depressed patient. So we try, what's behind this?
No, but I think
What-
you were suggesting that you should take away decision-making rights from somebody who's depressed.
No, I'm not saying that. I'm just saying that killing a depressed patient is not the best outcome in this situation. Somebody wants an overdose of barbiturates, which is a form of suicide. Prescribing that, agreeing that they have a life not worth living, isn't what physicians should be doing. This person should have their depression assessed and treated.
If that depressed patient was maintained on a ventilator and refused the ventilator and said you must remove it, as a physician, you would follow. And I assume that you would talk about the depression, and I'm assuming you would look into it. And I'm assuming that if the patient still maintained her insistence that she did not want to be maintained on a ventilator, that you would accede and assist in that
absolutely.
request.
But that's
Yes.
a category mistake. Somebody who's on a ventilator is in a different position than somebody who's not on a ventilator. Being kept alive by technology is a very different category ethically than just being ill.
Alex.
I think we have to get down to the crux of the issue. What makes assisted suicide different is that somebody's actually now going to intentionally write a prescription, or in the case of euthanasia, give you that lethal injection of some sort to cause your death. So now you have another person involved. So it's very difficult here, because when I hear a lot of these arguments around euthanasia and assisted suicide, people are arguing, in fact, the argument is really in favor of suicide. And I say, well, wait a second, but I'm not talking about suicide. We're not talking about the person ending their own life. We're talking about somebody else now. So now we have this whole problem. How do we ethically make sure that this person is protected in a society where we all have different values, where we all live together in different ways? And as Larry said, you can't assume that a doctor is a special moral agent.
Well, let me understand this, Alex. I understand that you're against assisted
Yes.
suicide. Are you against suicide?
Suicide is not the question at hand.
No, but that's the question I'm asking right now.
Well, obviously, I don't advocate for suicide, but I don't think it's the same thing. I don't think if someone decides to kill themselves, they're not involving another person. That's a totally different question than me assisting another person to kill themselves.
Again, on the continuum, though, a doctor injecting you with something that will kill you is different, is it not, from a doctor giving you pills, but then you using those pills at the time that you think is appropriate.
Yeah, legally, they are different in every way, absolutely, because one would be a euthanasia, the injection, the other one is an assisted suicide. This report would look at both as being something to be legalized, right? So, and further, the case in BC right now also in their definitions would include both euthanasia and assisted suicide.
Let's, Udo, just understand, this happens elsewhere in the world, right? There are 5 jurisdictions: Netherlands, Belgium, Washington State, Luxembourg, Oregon, the state of Oregon in the United States. So 2 American states and 3 countries in Europe where this is allowed. One of the major concerns that people have is that the elderly or the disabled will be abused if you give their, who knows, their family the right to presumably help them kill themselves. What's the experience in those 5 jurisdictions on that front?
Okay. I know you expect me to answer that in 10 seconds, I take
I don't,
it, right?
of course not. No, that's this is actually the program where you get to finish your sentences, so go ahead.
Okay, because I think this is it's a very important question. It's very contentious. We will very soon hear probably interpretations of the same facts that come to the opposite conclusion of what I'm trying to tell you now. What we have, because the fundamental concern is this: is there evidence that a more permissive regime would lead us down a slippery slope where people who might not want to get killed will get killed, and so on and so forth, as you mentioned. So to cut a long story short, we have seen evidence of non-voluntary euthanasia in all those places that you have just mentioned. Does that establish that the permissive regime was the cause of non-voluntary euthanasia? And the answer to that is no, because we have large-scale studies of societies in Europe where assisted dying is still illegal, and we have discovered that in percentage terms there are more cases of non-voluntary euthanasia than in European societies that have a permissive regime. And the evidence of that has been published in The Lancet. It's a peer-reviewed international medical journal. I think it's very difficult to argue about this. The other slippery slope strategy is to say, well, once we get started there will be ever more people included. And when you look at the numbers from the Netherlands, for instance, the percentage point actually of euthanasia cases is stable, has been stable for the last 15 years. So if you were concerned that you go down a slippery slope, you would expect there would be an increase, significant increase in numbers of cases.
Hasn't happened.
It hasn't happened.
Well, in 2009, there was a 13% increase in euthanasia from 2008, and the most recent numbers we just in the Netherlands, and in the most recent numbers in 2010, there's a 19% increase that just came out. So in fact, it is really opening up. Further to that, the whole point of the slippery slope.
I do disagree with you on this because
the whole point of the slippery slope is there is an assumption that we move from one thing to the other. But when I read this, the Royal Society report that you were chair of, your report actually justifies every form of euthanasia, basically, and then you just pull back a bit at the end saying, well, we're going to discuss the rest later. We're looking at voluntary euthanasia, etc. So in fact, if I were to read your report and look at it and analyze it in depth, I would realize that, in fact, everything's basically justified. We're just going to get there someday, and that's okay. Further to that,
I have no idea what you're talking about, but
Well,
it sounds nice.
No,
it sounds nice, though.
It's
a good
true,
propaganda
though.
tool for your website.
No, it's absolutely. I'll go through it with you again.
Good
see
for
what
you.
said. Further to that, in Belgium, where euthanasia is legal, there was a report that was published in the CMAJ last year, which showed 32% of euthanasia deaths in that Flanders region of Belgium were without request or consent. So that's a huge number. That's a massive number, and that's in a nation where it's been legal for a very long time.
Can we just understand, are we agreed on those facts?
I would
we are
completely
absolutely
reject
not.
Udo's analysis of Holland. And I'm in good company rejecting his analysis of Holland. The House of Lords Select Committee completely rejected it. They went to Holland. They came back and they said they were shocked by what they saw. They did not want that brought into England. They don't have it as a result.
Here's my job tonight is to try to, not get you to agree on an outcome, but at least get you to agree to debate on facts that are
You know what would
in
be
common.
nice?
Stand by, because I hear one side saying there's no evidence that there's been a slippery slope or an uptick, and then I have you guys over here saying, what are you talking about?
You know what
It's
would be
20,
nice?
30%
A
higher.
dissenting opinion in the report. if that committee that did the
right.
report had been better structured, you would have had somebody able to do a dissenting opinion who knew the area as well as the people who wrote from their highly biased perspective.
You have a report that's a one-sided report, and that's what you have. So therefore, it examines issues and it comes to one conclusion right throughout, instead of what would have been very helpful to Canadian society if the Royal Society had one report with different groups of people within that report, and you might have ended up with two different reports, or you might have had a report.
Opinions.
You might have had dissenting opinions,
Well, let's
etc.
take
But
a
at least
second
we
here
would
on
have had a
this.
full
Okay,
analysis.
hang on.
for
Let me
Canadian
ask the
society.
charity. All
But
right.
we don't have that.
The panel was composed by whom?
There's two parts, right? We had lots of claims, factual claims that I disagree with. But no, you want me to talk about something else, about the composition of our report. I just want to be clear where we
Well,
are.
they're related.
Stand by. I'm operating on the assumption that we're not going to come to consensus on those facts that we were just discussing.
That is
but
correct.
I think
Okay,
I think you can talk about who was on the panel
Okay.
and how they got there.
How they got there is, I can tell you that I, for instance, did not make the decision as to who is on the panel. The panel was made by a committee of the Royal Society that appoints people. And this committee consists of a whole bunch of people, and they look at CVs of people that are proposed to this committee. As I said, I have not chosen people. What I do know is that on the panel were two people at least who were outspoken proponents of a permissive regime with regard to assisted dying. I think it's fair to say that most of the Canadians, the Canadian participants, do not belong into that group of people. They have actually, like Ross Upshur, has never published anything on this issue,
So the
never uttered a word
participants
on
were
this.
from countries all over
He's
the
a
place?
clinician. Yeah, exactly. I mean, we had experts from the Netherlands, from Britain, and from Canada. So I just basically I reject the proposition that the panel has been prejudiced in any way just because there was a small number of people on this panel
Okay. And for
that was in
those-
favor of decriminalization.
And one last thing on this. For those who don't know what the Royal Society is, would you give us the 10-second speech on what they do and who
This
they
wasn't
are?
the Royal Society. This was a small group, a committee. There's only two members of the
Oh,
Royal Society on the committee.
Oh, so you have to be very clear. The Royal Society basically is something like a national science academy in this country. It is very old, and what they do is they commission expert reports, and like the oil sands, for instance, on all sorts of issues. And they bring in who they consider are the best people. And no wonder the guys who didn't have their spiel in the report because they disagree with it will say, how biased, how biased, how biased. If the report had said the opposite, trust me, you wouldn't be sitting here complaining.
That's
when
not
the
true.
committee came together 2 years ago, you could just go straight to my blog and see it. I said, this is going to be a one-sided report. Look who they've appointed. I said, why don't they just simply appoint groups of people from both sides of the issue and send them out to get their same research, then come back and write a report?
Okay.
I
It
don't know
lacks
why they didn't do
credibility.
that.
You know what?
In the Royal
You know,
Society, you have one of Canada's leading medical ethicists, Margaret Somerville.
She's not
She
in
should
ethics. She has no ethics training, my friend. She
Margaret-
has no ethics training. Go to her Wikipedia
Obviously
site.
Okay,
touched the button there.
gang, I'm bringing down the gavel here. We're not going to talk about how the report was put together
she is a
anymore. We're
member
going
of
to
the
talk
Royal
about
Society.
what's in the report. Alex, stand by. And I want to go to Larry on this. Would we be having this discussion at all if we had better palliative care in this country?
I think the discussion would be less intense if we had better palliative care, because we know that about 70 to 80% of Canadians do not have access to good palliative care. And there's lots of misunderstanding around. I think Joan makes a very good point in the Nancy B case. Lots of Canadians are not aware that they can say no to medical treatment, and that's a very important case.
Yeah.
And it's important for doctors to know that, it's important for patients to know that. But every day in Canada, people are dying because they are not getting good pain and symptom relief. And those techniques are available, that's been studied, it's a well-developed area, but 80% of patients, dying patients, not having access to palliative care, it's a scandal in Canada. So part of the drive for euthanasia comes out of that desperation that those patients and families have, and it's
And fear.
understandable.
Joan, let me hear Joan, please.
And I was going to say, I agree with Larry that I think that the discussion, though it would not go away, would be less intense if we had better palliative care. And I fully support a better palliative care program in this country. It's interesting that we pay a great deal of attention to issues of assisted suicide and euthanasia, but there was a recent parliamentary committee report released about the need for a national palliative care strategy that has not got nearly the public attention. So it is important to improve palliative care and improve its ability, its availability across this
I just
country.
want to make sure I understand what you're saying, though. If people who were close to death knew that their death was not going to be gruesome and painful, they might change their mind about trying to take their own life. Is that what you're saying?
They might.
They might.
That, to me, does not change my view that it is still important to have an ability to choose assisted suicide or voluntary euthanasia for competent adults.
Okay, the flip side of this argument is, okay, Udo, go ahead.
I just wanted to, because this is, I think, a good opportunity. This report is being sold as a euthanasia-type report. People who read it carefully will see that there is an extensive analysis of the quality of palliative care in this country. We have a whole range of recommendations with regard to improvements to palliative care. I just wanted to mention, in addition to what you said, and for one, we probably agree on this particular issue, at least on this table, 5% of, only 5% of children who could benefit from specialist pediatric palliative care have access to it. What this means is that 95% of children who could benefit from specialist palliative care in this country have access to it. This is a scandal.
So that leads me to my next question, which is the flip side of what we just talked about to Alex, which is, given the country we live in, where we don't have the kind of palliative care that might make different choices happen at the 11th hour of one's life, do you have to allow for an extra option for people? Because we don't have the kind of palliative care that you think, that everybody wishes we had.
Well, there's two ways to look at it. One would say, well, if we don't have this option in place, then at least give them assisted suicide or euthanasia. But the other side is, what kind of choice is it when you're thinking that, you know, am I going to die in pain and suffering, or do I have excellent care available to me? You know, our polling shows that the reason that there is a fairly large number of Canadians who say they support euthanasia assisted suicide is because they fear a bad death. And so we've specifically asked these questions, and so we want to see that dealt with first. Now, Joe mentioned the recent parliamentary committee report, and that report looked at how to implement better palliative care throughout Canada, and it recognized, especially in rural communities and the Native community, et cetera, that there's really almost no proper end-of-life care available to them. So in fact, you know, who are we abandoning by looking at euthanasia and assisted suicide without first looking at how to care for people?
Okay,
But
Larry, if we, all right, so go
Steve,
ahead.
if I could add
Yeah,
to
you-
that. Els Borst, who was Minister of Health in Holland when the law changed there, has said in an interview in 2009 that she thinks Holland moved too quickly and that the quality of end-of-life care has decreased since legalization, and she regrets that. Now, I think we should take a serious look at that insight from the Minister of Health at the time in Holland and put our emphasis not on moves towards euthanasia, but on moves towards increasing palliative care.
Well, that leads to the next question for Larry. Do you think it would, this is a terrible word, de-incentivize?
Yes,
Take any
yes.
incentive away
I
from the
think-
state
I
to
think-
improve palliative care by allowing physician-assisted suicide?
That's the concern, because to me it's a cheap and, from my perspective, violent solution that doesn't fit with Canadians' compassionate desire to have a national health system that supports our desire to care for one another. It's one of the few things that defines us as a nation, is our commitment, you know, to publicly funded health care. And this is an essential publicly funded health care.
If we're talking values, though, where do you put the value on autonomy?
Well, autonomy, you know, is a value, but is it separate from our embeddedness in our communities? You know,
Well, it sounds like for some people it is.
In fact, when you look at surveys that have been undertaken in Canada, even by pro-life organizations, let's face it, consistently they show significant majorities in favor of Canadians in favor of a more permissive regime with regard to assisted death.
Yeah, but
And just to be clear, because we don't really have this conflict. I mean, in our report, we made very clear that palliative care has to be improved. We suggested oversight bodies that basically ensure that even if a permissive regime was introduced, that we improve on the quality of palliative care in this country, because it's necessary regardless. But what is also clear is that no matter how much you improve it, you will still have people that are not happy with the palliative care option. And I give you one example. A colleague at Queen's University died of cancer, and she died an absolutely horrible death. She refused palliative care because, as she said, I don't want to be a zombie. I don't want them to switch my brain off. And
but that's not good palliative care, though.
Well, according to you, maybe she had the best palliative care.
They don't need to be a zombie.
But no.
Proper care.
What I'm trying to say is, she had access to specialist palliative care. I'm sure you're the expert. Let's just say she had the best care that was available at the time, and she was not happy with what was on offer. The point is, there will always be people, regardless of how much you improve palliative care, that will ask for this sort of option. And this is why it will not go away, no matter how you try to
I did mention, just one second, because I did mention at the beginning of the program that people were going to tweet and email in their comments tonight. We've been putting them up on the screen. And Joan, I want to put one of them to you that came in earlier. It's generational. Boomers want quality of life.
True.
Is that right?
Boomers want quality of life. I think boomers and I think all people want to make their own decisions about their own lives. And so, though I am a boomer, I don't think you can just dismiss this as though it's all just my generation.
But the suggestion here, I think I'm inferring this, but it sounds like the suggestion is the generation before the boomers might have been prepared to be more stoic and put up with whatever. Boomers won't. They demand a certain quality of life. They demand the right to choose the timing of their own death. Is that right?
Well, certainly a number of people are saying that we should have a right to choose the time of our own death.
Joan and Steve, that's a suicide argument.
But
That is. It's not about, this is about having somebody else involved with causing your death. So it's a totally different question.
And
again.
physicians, the very people who traditionally have been dedicated towards therapeutic help and cures, medical improvement, not killing.
And all of the research looking at those requests, done in Winnipeg by Harvey Chochinov, a palliative psychiatrist, identifies that the question behind that is, do you think I'm worthwhile? And the development of dignity therapy, where you're looking at how do you hear that person's story, how do you help them find meaning in the face of their suffering or anguish, is the response, not killing the patient.
Hang on. Can I ask you this? You're a doctor in Manitoba. Do your colleagues sit around and talk about this at all?
I think it's debated among doctors, and it's debated among medical students too, as part of the ethics thinking.
So doctors do not feel uniformly about this issue?
No, I don't think they feel uniformly about any issues.
Okay, so I'm leading the witness here.
Yeah.
So have you, I'm not saying it well, do you know doctors who would prescribe those barbiturates and help somebody kill themselves?
I don't know of any that I can think of right now. Most of the physicians I know are more actively involved in palliative care leadership in the country and in the province.
Udo, do you know people who would do that?
I need to respond to the dignity stuff, Chochinov studies. This is really important because we actually looked at all his work, and it's very clear. He did not like to concede it, but he conceded in the conclusion of his own work that it is clear that with whatever the improvements in palliative care will be, some people will continue to request assistance in dying. He himself concedes that. So this is why I have difficulty seeing that we can talk it away by saying palliative care, no matter how often we mention it.
Well, I don't think we can talk it away ever. But the question is, who else is involved here? What happens
volunteers, crucially volunteers.
What happens to doctors? What happens to nurses? What happens to family members? What happens to the disabled and other people with similar problems when euthanasia is offered as an option? Those who are left behind. I think there's lots of.
If I could say a word about autonomy, there's a very strong critique that what is behind this drive in the euthanasia movement is a radical view of individualistic autonomy. The Royal Society Committee report very much starts with autonomy as its ground. That's a radically emaciated view of how to approach this issue. The better view of how to approach life in community, which is what this is really about, is that we aren't just monads, aren't autonomous beings cut adrift from every other relationship. The reason hospice care and palliative care is so critical in this discussion is because it sees the person in relationship. We live in relationship, we die in relationship, and how we die influences not just us, but everyone around us. And that's why this issue attracts so much concern from disability groups.
I want to ask Joan about politics. When the Royal Society...
An answer about autonomy.
Oh, all right. Stand by. When the Royal Society report came out,
Yes.
the Conservative government said, we're not touching this.
Yep.
The New Democrats said, we're not touching this.
Nope.
The Liberals said, we're not touching this.
Nope.
Everybody ran screaming as fast as they could away from this issue.
This is not an issue that is, I don't think, going to get onto a political agenda anytime soon. I think it is far too contentious for political parties to deal with. And I've been working on this area for a long time. It's not come up to that level.
What did you think of the response of our parliamentarians?
Well, I think it's sadly increasingly typical. On many issues, we devolve to the courts, issues that are not best settled by litigation. I think that one of the real problems in Canada is that we're far too ready to go to court when we should actually be working things out through civil society debate and analysis.
If Parliament doesn't want to touch it, though, how are you going to do that?
You do it through the democratic process of discussion, debate, and eventually, in the case of medical education and cultural awareness, which is what this is about. I mean, a lot of people are discussing this issue as it was said right at the beginning, in terms of fear of dying badly. And many of those fears are justified because of the education isn't there in terms of pain treatment and so forth.
Alex.
Well, Parliament did deal with it last year, and it was debated, and it was debated for a fairly long period of time, even though it was a private member's bill. And the reason was is that that vote was constantly delayed and et cetera, and it was defeated 228 to 59, which is incredible if you consider the parliamentary makeup at the time last year.
Okay,
and
those
now,
who lost that vote, forgive me, but those who lost that vote would say the MP who put that forward isn't there anymore, and many of them, probably most of the people who participated in that vote aren't there anymore either. We got a whole new crop of characters up there now.
a lot of them aren't there. Now there's a parliamentary committee report that's come out. I was trying to get back to that because that report looked at issues around palliative care, which were very important. It had a very large section on that and how to deal with that issue, but also looked at saying, hey, we have no suicide prevention strategy in Canada. There's no national suicide prevention strategy. There's the province of Quebec has a provincial suicide prevention strategy, and it tied that into saying, you know, how are we properly caring for Canadians? And then it looked at the issue of elder abuse. Very interesting. They identified very clearly we have a significant problem with elder abuse in our society. So the question comes back to I would ask, how are you supposed to have a safe regime with euthanasia and assisted suicide when today we're already having this huge problem with elder abuse that is not receiving protection for elders?
Okay, we've got just a few minutes left here. Go ahead.
So
you want to
a
respond?
couple of things. One is that with respect to elder abuse, our current regime is certainly not doing well, not doing enough. And I don't think that the prospect of legalized assisted suicide or voluntary euthanasia has to necessarily come with safeguards that are not effective. But that's essentially what you're saying, that there's no possibility of implementing effective safeguards.
In that type of a vulnerable situation.
Pardon me?
In that type of a vulnerable situation, safeguards would be completely ineffective.
And I disagree with you on that.
Which I expected, but that's fine.
And I think that the Royal Society report has begun to outline some of those safeguards. The other point that I wanted to come back to was one that you had raised, Ian, with respect to autonomy, which is that autonomy is a value that is reflected very strongly in our Canadian Charter of Rights and Freedoms. And it is focused on the liberty of individuals in Section 7 of the Charter, and it's focused on equality rights in Section 15 of the Charter. And I don't think that we can forget that as part of the makeup of our country, because it is.
I think there's a very important discussion that is starting to happen there. I think for too long, rights theory has been focused on individualism, and I think increasingly that consensus is breaking down as people realize the need for associational recognition, the need for equality to be seen contextually, particularly in relation to religion. Religion is not just an individual right, and these recognitions in the law, which are slowly evolving through jurisprudence and need to go further, will, I think, bring us to a much more communitarian understanding of how we live together.
I got 30 seconds left, and Mr. Chairman, I want to give it to you because I'm wondering whether, given how parliamentarians have run away from this issue, do you anticipate down the road that provinces will take over this issue and simply give directives to their law enforcement officials and say, don't enforce, just turn a blind eye?
We mentioned that as one possibility, as one legal possibility, one legal avenue that they could take in the report. And we will see what happens. My suspicion is that this will go to the Supreme Court eventually, and the Supreme Court will settle it. And I do believe that the Supreme Court, once the evidence is evaluated with regard to these abuse claims that exist today, that didn't exist during the Rodriguez case, I suspect the decision will be quite different.
Okay. I want to thank all of you for coming in tonight for what is a very difficult, thorny, tough issue, which you handled in mostly a civilized fashion tonight. So appreciate that very much. Udo Schucklink, who is the professor of philosophy at Queen's University, the chair of the Royal Society panel, Joan Gilmore, the professor from Osgoode Hall Law School, Alex Schadenberg, the executive director of the Euthanasia Prevention Coalition, Ian Benson, senior associate counsel at Miller Thompson, and Larry Reynolds, the professor of family medicine, University of Manitoba. Thanks so much, everybody.